When it comes to cardiovascular care on the organizational level, MedAxiom, an ACC company, understands the challenges your program is facing. Welcome to MedAxiom Heart Talk, the podcast where thought leaders come together for one ultimate goal: to continually transform and optimize cardiovascular care for all. MedAxiom Heart Talk starts now.
Welcome to our weekly COVID-19 briefing, everyone. I'm Cheryl Toth, host of MedAxiom Heart Talk. We're continuing to bring you answers and insights from physicians and administrators on the front lines. Since the start of the pandemic, cardiovascular programs have been shifting from in-person visits to telehealth and virtual visits. And of course, as you all know, this shift is happening incredibly fast. The MedAxiom listserv has been really lighting up with questions about many of the aspects of making the change and making the operations work, from explaining what a virtual visit is to patients, to getting the video to work. All kinds of questions have been popping up. So last week we talked about coding for these visits, and in today's briefing we're going to discuss some of the operational issues many members are facing and talking about. So joining us from Grand Rapids, Michigan is Ginger Biesbrock, Senior Vice President Consulting at MedAxiom, and our guests from the front lines today are from Sanger Heart and Vascular Institute, part of Atrium Health. So joining us from Charlotte, North Carolina, are cardiologist Dr. Bill Downey, Vice Chair, Quality and Care Transformation and Medical Director, Interventional Cardiology, and Jenny Villafane, Director of Virtual Care. Thanks everyone for being here today.
Thank you for having us. We're happy to be here.
Thank you very much.
Yes, thank you, Cheryl.
So Ginger, I'm going to start this with you because a lot of members are asking questions about telehealth on the listserv. Give us a sense of the most common questions you've been seeing over the last week or two, as well as what you're hearing from programs out there as you talk with them about this.
Absolutely, thank you. So yes, this has been a very hot topic and a very valuable tool for us to continue to deliver care in this current COVID environment. So there's really been a couple things. One related to deciding on which patients and how. So especially as we think about new patients. Originally, when this first rolled out, the options were much easier with our follow-up established patients. But then many of us began utilizing this for new patients as well. So we saw a lot of just questions around how do I decide which patient can be most effectively managed in this delivery model. The second question that we hear a fair amount, and actually even up until I think I saw some questions on this yesterday, was related to engagement with our patients. Some programs are really struggling with patient engagement around utilization of the video technology. And while others have developed some good best practices and how best to engage those. And I'm very anxious to hear from Dr. Downey and Jenny today about how they've done this in their program. But that whole kind of patient engagement and how do we empower them to utilize that technology. And then the third area, of course, is always around the billing and the coding. So we've had a lot of revenue cycle questions in which we've also developed some good tools for. So just really understanding the reimbursement models related to telehealth.
Yeah, and some of those we've it's always good to mention are in the COVID-19 resource page. There's a billing and coding tool that's very comprehensive, and you've been updating it with the latest information because things keep changing over the last couple of weeks. So that's there for listeners if they want to get that. It's at medaxiom.com/COVID-19. So good. So those are the three main areas that we're hearing from members. Dr. Downey, give us some insights about how you're dealing with some of those. What were some of the challenges that you are facing or you faced at SHVI as you rolled out telehealth during this pandemic? And I'm curious, were you offering virtual visits before COVID-19 as well?
Effectively, no. Our heart failure program had a telephone-only post-discharge program that comprised way less than 1% of our total visits. Our system did have a telehealth urgent care platform and an EICU platform, but they were both completely foreign to all of cardiology and almost all of our providers, except for the specific EICU physicians.
So as
so it's been completely new for us.
Mm-hmm. So as you've rolled these things, as you've been making the switch, tell us about some of the challenges that you've been facing. What are you seeing as as you've deployed and implemented the virtual visits into your patient population?
I think, frankly, as you redo every part of your practice, everything's a challenge. So each of our colleagues, our medical office assistants, our office nurses, our administrators, everyone's job got redefined, not just the physicians with this. And so everyone had to have flexibility, but needed good leadership to figure out, all right, what exactly is this new job? Where we've been able to transition, over the past 3 weeks is, yesterday, out of 450 total visits, 2% were in person, 55% were over the phone, and 43% were video. And today we will break the 50% video mark, aiming to get to 80% by early next week. But really, I think it's probably worthwhile going through each phase of the patient's journey, because each step required a complete redo of everything we do in ambulatory care. And Jenny's really been instrumental in that.
Jenny, why don't you sort of walk us through that kind of? I mean, you were the former director of virtual care for Atrium Health, the system, so you're very familiar with building virtual programs from the ground up, from the workflows and the tech and the billing, patient experience. So how did you do that, as you think about each step of the journey, the patient's journey during this pandemic time? Where did you start, and walk us through that?
I think we were very fortunate that within Singer Heart and Vascular Institute that we had a comprehensive virtual strategy that we were looking to deploy later this year. So some of the areas in which we rolled out as part of this transition for COVID-19, we had some discussions around what are potential workflows. So one example of that would be for our triage workflows. We had already identified a small pilot that was set to begin in early April, where we would, for patients who called into our triage line and we felt like they needed to speak with a provider, we could go ahead and schedule that phone visit with the provider. So we had a strong foundation and plan. I don't think we ever expected to accelerate it as quickly as we did, but that did help us move pretty quickly. So that was one thing that benefited us in our rollout. I think the second thing that really helped us was understanding where to start. So knowing that we needed to transition very, very quickly, we decided to start with offering phone visits for our patients. So that really let us test out some of the workflows for the teams with phone visits before transitioning to video visits. That foundation helped, I think, increase the comfort of the staff in caring for patients in a different way, and for communication to patients about their options.
That's a great idea to test the workflows with phone visits before you move to video. But Jenny, why don't you tell us a little bit more specifically, what does that mean? What were you testing? What were the flows? What was the experience as it rolled out?
We first had to consider all of the components of a visit for our standard, just traditional in-office visits, and then think about how are we going to transition each piece of those when we were all going to be remote, including the patient. So for example, we had to figure out that initial outreach. So who were we going to outreach to? So we worked with our providers to identify the patients that would be appropriate to transfer to a phone or video visit. From there, we had to understand, okay, how are we going to arrive these patients? How is the providers going to know that there is a patient that they were ready to see and document? So those are some of the initial questions that we had to answer when we were thinking through about the transition. And what we came up with was a flow that we have tweaked over time, but has worked really well for us. And that's where the providers identify those patients that we are transitioning for scheduled appointments, and the clinical team or clerical team, depending on the outreach, will actually call the patient, let them know the provider's recommending a video visit in this particular scenario, and that we were going to get them set up. From there, we went ahead and then scheduled those patients for either a phone or video visit within our Epic schedule, and then a day or a day before the visit, then we actually had one of our clinical teammates, our MOA or RN, reach out to the patient, complete the medication reconciliation, so that when the provider was ready for the patient, it would flow just like a standard office visit. So we tried to keep the flow as close to a traditional office visit as possible. We just did the different components and steps at different times.
And I'm curious, Jenny or Dr. Downey, either one of you, I'd love to hear from both your perspectives. What would you say are some of the lessons that you learned throughout that process of laying that out and testing it? What were some of the learnings so far?
I think the first one was I expected some reluctance on the part of the patients. And frankly, we just haven't seen that. What we've seen has been gratitude on the part of the patients that they're not coming into a high-risk environment, and that we're putting forth an effort to help them avoid exposure. I expected to see some mix, and it frankly has been, 100 to 0 in favor of staying away out of a true ambulatory environment. Mm-hmm. So that was a concern that I had that frankly just never materialized. Questions we did have to answer and work through were, what really is the best phone number to reach the patient at? Often it's not the one that's front and center in the chart. How do we know and document that the consent for a virtual visit has been done appropriately? How do we know that the patient is within state so that licensure things are covered? This was prior to some of the waivers that have been helpful subsequently. And what we were able to work at is the person reaching out to the patient a day ahead of time, typically a medical office assistant, would document in a way that comes up front and center for our physicians on their usual scheduling template that says, here's the best phone number for the patient, your consent was done, medication reconciliation done, patient is in a state where you're licensed. And it's right there front and center and well documented in a permanent way, so that really as the provider in our initial days of doing a telephone, all you had to do was look at it and dial the phone number that was given to you. Well, it made it very, very similar to our usual ambulatory workflow, and we're able to tell our providers, look where you usually look. The information will be a little different than what you have, but dial the phone number we told you to dial and provide the care that you usually provide. And that made it pretty easy for them to swallow, and therefore pretty comfortable for the patients.
I think that's great. And Jenny, did you make a new form or a workflow in Epic, or are these paper forms? How did you get it's almost like you created a new centralized face sheet or something with all these pieces of information that might be pulled from other places. How did you tee up the provider with that information?
We really relied on our existing systems and just scripting and operational guidelines. So most of the flow for the visit, we documented in an operational guide for our staff, as well as an operational guide for our providers. We tried to keep the system changes as minimal as possible, but we did have to make some updates. For example, for our phone visits and video visits, making sure that we were using the appropriate appointment types within our Epic schedules so that the providers and the patients knew what type of visit that they were going to have. So that did require some build to get those pushed out to all of our team's templates, but we did try to make the changes as minimal as possible within the system and really using the scripting and the guides, at least initially, to get the teammates used to the new workflows.
And
I think critically, Jenny and her team pushed out scripts to our scheduling folks and our medical office assistants and nurses that very explicitly said, this is what you need to tell the patient on the phone. Here's the language of the consent. Here's the check boxes you need to go through. So it was, while different than what they were used to doing, was very easy to go through a to-do list that had the language right, made everything compliant, and got everything accomplished efficiently for them.
On the physician side of things, Dr. Downey, what tips do you have for your peers that are delivering these visits? So we're talking about phone right now. I guess you could either phone or telehealth visit, either one you can answer this for. But what did you find, or what are you and your colleagues finding, is making for a positive experience for patients and for physicians? So the checklist and all of this information has been helpful getting you up to the visit. What about once you get into it? What are some of the tips you have for listeners?
I think one of the things that's really helped is beginning the phone visit by expressing gratitude for the patient for being willing to do this in a different way than we usually do it, and that we're doing this to keep them and the other patients safe. Beginning it with that, I think, sets the right tone and makes the patient feel positive about the reason that they're doing something different that they're probably a little uncomfortable with. But when they start the visit feeling good about themselves, things are likely to flow positively from there. Then you kind of move into your usual conversation that you would have with a patient. And I think it becomes very natural for both very quickly, whether it's a telephone or video.
And Ginger, what are you hearing from providers out there, whether it's physicians or APPs, in terms of how they sort of best practices, if you will, that they're finding work well in the phone or virtual visit environment, video visit?
Yeah. I think it's really what Dr. Downey and Jenny have outlined, and what I want everybody to hear is the amount of structure and planning that has gone into this, although very quickly, the scripting, the preparation on the front end, the patients and the providers, when they get to the point where you're having the patient-provider interaction, somehow we need to not have the technology be the front and center. In other words, we can't be trying to fumble around figuring out the video or, trying to figure out the phone. Not that those things aren't going to happen, they are, but the work that we can do on the front end with the patient preparation will really improve the engagement when it comes to the actual visit and the interaction. The other thing that does is it streamlines the processes for the providers, because again, we really want to utilize their time in that patient-facing clinical evaluation, decision-making sort of way. So the more work we can do on the front end around preparation, the better. I would say in addition to that, we need to treat these like any other visit. So that chart preparation, making sure that all the information is available, making sure the I's are dotted and the T's are crossed, and all of those things that we would do in our normal face-to-face visits. That same preparation process needs to occur for these visits. And the more we can do that work on the front end, the better and more effective these visits will be, because now it will be less about the technology, less about not knowing, having to ask those extra details from the patients, and then we can really concentrate on what we need to do in that particular time.
I think her point about getting the technology out of the way and letting it be a tool to facilitate the visit, not the focus of the visit, is really critical. One really nice piece of advice we got early on was, and built into our script, is as we begin to talk about video visits, telling our patients, do you FaceTime with your grandkids? And they'll say, sure. You say, well, this is pretty much what we're doing. It's just a little different platform than FaceTime to meet some regulatory requirements. That then feels pretty comfortable to them, because many have done that.
That's a great idea, putting it in context, something that they're already familiar with, so they don't realize right away until you say that this is really the same thing, just a different platform.
It feels a lot different to hear this is FaceTime with your grandkids than you're having a virtual cardiology visit, which is not so clear what that means.
Right. Yeah, and the communication piece, let's talk about that for a second, and how you're conveying, whether it's phone or video, these virtual, non-in-person visits. How else are you communicating it with the patient? I know there was something on the listserv this week, Heart and Vascular in Wisconsin, I think, was they've put a video on the website how to start a virtual visit, and some folks are talking about one-sheeters that are going out to patients to explain it. How have you done that to communicate what this is to people even before you get to the actual visit itself? Jenny?
We're really relying on, at least initially, that in the outreach that we're making to our patients as we're transitioning them from a in-person office visit to a video visit. We do have patient education material that actually has been most beneficial for the staff and the team who will be doing the initial calls with the patients to transition them. So we wanted to make sure that the team felt very comfortable with what they were asking patients to do. So we found having that patient experience collateral was most beneficial to the team, and then really letting the team walk the patient through what the experience would be like. We are looking at some specific marketing campaigns around what patients can expect through these type of visits, both within Singer Heart and Vascular Institute as well as the larger system as a whole. But primarily right now, we're really relying on this team reaching out to patients and communicating what the visit will be and look like. So
you've really educated your own internal team really well, and they're conveying the information on the phone. So patients aren't reading, or it's more personal. That sounds very personal to me. I think patients appreciate that, I can imagine.
Yes, absolutely. And I think one of the things that we have learned is if our teams are really comfortable with what the experience looks like, if patients get a little nervous or intimidated by doing a video visit, we'll occasionally hear, oh, I'm not very good with technology from patients, or I don't know about that, I'm not sure I could do that. With the staff feeling so comfortable with it, they're able to reassure the patient that, we are going to send you a link, all you have to do is click on it, and I'm going to be here to walk you through it. And that personalized outreach has been really effective in patient adoption and comfort with the video visits.
Well, and now let's move over to the video visits. Let's talk about the actual turning the video on. Again, something we're seeing a lot of on the listserv about what do you do when you can't get the video to work, and how do I document this? So tell us a little bit, Jenny, about how the experience has been with the video visit versus phone, and what you've learned so far.
I think this is one of the areas of our biggest learnings throughout our journey. We did start with trialing a couple of different platforms before we scaled out to the larger provider footprint. And we really went down the route of trying to leverage some of our system standards for video before trying to go out and look for other options in the market. So we did have a small group trial some of those system standards, and what we learned from that experience is ease of use for your technology platform is critically important and foundational to your success. Our existing solution did not have the ease of a text message or link. It required patients to download an app and create an account. That was very intimidating for our patients. So in that initial kind of cohort of pilot patients and providers, we learned that, and very quickly were able to find a solution that was a little bit easier to use. So once we had the right solution in place, then it was really adjusting and adapting our existing phone call workflow and integrating the video component in there. I think the biggest change that we had to make to our workflow was really, how do we get the link to the patient? So how do we communicate where they need to go and what they need to do? So what we were able to do is, in our initial scripting for the practice staff, once they offered the video visit to the patients, the patient accepted, we did send the patient an email with a link to their video visit. In that email, we had a few basic instructions and also included some of the informed consent, but that served as their communication on what to do with the visit and when they were supposed to arrive for that visit.
That's a great workflow. I'm imagining that when it's all in one place, like you're saying. Actually, I had an experience with a physician just 2 weeks ago as well, and it was a platform I wasn't used to, but it was really easy, and I got in there, and everything was right there. So that is a very great way of handling it from the patient experience side that I had. I am curious what you both think, Dr. Downey and Jenny, if you were to kind of say, hey, there's two things programs really must do to be successful with that the video component. What might those be to make sure they have those in place? I'm hearing from you, Jenny, that might be the user-friendly app or platform. What else would be really important?
I think the critical piece is finding good workflow for the providers and the patients. And what we found is the platforms that provide good workflow for the patients tend to be great workflow for the providers as well. So there's a nice match there. There are some that I think are, quote, more robust, in that they may offer a bit more of an end-to-end solution for what video visits were 2 months ago, pre-COVID, and there was an industry around that. In many ways, we don't need all the bells and whistles that came with that, and some of those bells and whistles that we at least found were getting in the way of patient and provider adoption, when we didn't actually want those in the first place. And going with simplicity, that required us to adapt. I think Jenny underplayed the amount of adaptability that came in the early phase. We rolled out one platform, tried it for a day among 4 providers who were known to be early adopters and eager to use it. And it was clear that this was not going to be the total solution. And though we had put 4 or 5 days of work and scripting into it, threw it away after one day and moved on to plan B and redid all the scripting. I think that that adaptability made a giant difference. I stress that because new platforms have been popping up every week through this crisis as multiple companies try to serve our needs. And I think that we are not at the end of the line for what optimal is going to be there. And so continuing to ask ourselves, what's going to provide the best experience for your team's workflow, your providers, and most importantly, ease of use for patients. is absolutely critical, and will be different 2 weeks from now than it is today, and today is hugely different than it was 2 weeks ago.
Dr. Downey, let me just point out, I think this is such an important thing to say that even when you have a plan, if it doesn't work, it's okay to throw it out, like you said, and start over and try something else in this kind of a fast-moving environment. You have to. We talked with Joel Sauer last week on the podcast about this, about rapid design, and you just have to be flexible to say, okay, we tried this, it didn't work, but we're going to try something else now, and that may be different 2 weeks from now. So that adaptability is so important, and it sounds like that's exactly your physician group is very open to that. Very positive.
And I think the challenge that comes with that adaptability is, in our group of about 250 providers, that's a challenge and requires more than daily communication about, thanks for being willing to roll with the punches here. Here's how this is benefiting you and your patients. And by the way, we're not done with the turbulent times. Mm-hmm. But that continued communication is, absolutely necessary. It doesn't mean there aren't bumps in the road, but it at least helps you get over the bumps. And
Jenny, how about you? The two or three things that are the must-dos to be successful with the video. What would you say?
Yeah, I think Dr. Downey hit on the critical and most important one, which is provider buy-in and flexibility. And I would just add staff flexibility along with that as well. Their ability to identify what's working well, what's not working, and then sharing that with all of the different teammates, I think has been really, really important because it allows us to identify really what is that optimal process, what is that optimal scripting for our patients. So I think that's really important. Two other areas that I think are must-haves are really involving your clinical and clerical teammates in the design of the workflow. So you can capture all of the lessons learned and make sure that they feel they have a voice, and they do have a voice in the process. That has helped us immensely. And then lastly, I think it's making sure that we have the tools and the resources to support our patients and teams as we implement these solutions. And in this time, it's not the same as in a traditional environment where you have a lot of different folks that maybe you can pull on from across the system or other areas. Everybody needs to be on board and learn a new set of skills and do it very, very quickly. So making sure you have those tools, and some of those tools can be as simple as an operational guide or scripting, or it's just access to testing out the video technology so that they can really feel comfortable with it, and then making sure that we're all willing to pitch in. So if we're having challenges, or one area is having challenges with video visit adoption, can I jump in there and really coach them through pitching the video visits to our patients? So I think having all of those things in place will really help you be successful in transitioning to video visits.
Well, and Ginger, what can you add to that from what you're seeing in the field and hearing from members?
Yeah, absolutely. So I think actually what we've heard today and what we've seen today with Dr. Downey and Jenny is a fabulous best practice, meaning that we have a physician champion and an administrative leader that has taken this on as their primary role to help support the organization as they move through this. I mean, you've got to have those key folks. And to Jenny's point, bringing in all the different folks that touch the process and getting them into a room. And so some places may do this like a task force and have a small representation from each area. They get together even on a daily basis or a couple times a day as you're working to roll this out to monitor the processes and make those adjustments in real time and then provide that nimbleness, but then also to provide support to the team. For any of you, and I think we probably have all done this, if you've rolled out an EMR, it's the same concept. You've got some super users, people that are very comfortable with it. You've got a team that's constantly looking at those processes in real time to make sure and tweaking where we need to tweak. I love Dr. Downey's example of, hey, we tried something and it did not go well, and we were able to quickly flip that. Well, you can't quickly flip it if you don't have some people that have been designated as kind of the taking this thing on and leading us through the transition. Mm-hmm. So I think that in and of itself, if you haven't identified those key folks and then given them the time and the resources they need to really lead the rest of the organization through these processes, is something that you need to do. And the other piece of this is we don't know exactly what this is going to look like post-COVID. The waivers that have allowed us to get the current reimbursement do have expirations, but there's going to be a lot of work in how we can extend some of these really great services. And so the work that you're putting in now is going to be something that we will be able to learn from and continue well into the future. And so having that structure in place for the leadership and the operational rollout will serve you well into the future.
Great. Now let's end on a positive note with our story of the week. I'd like each of you to tell us about an innovation or something you saw, something that happened over the last week that was positive and really good. And Jenny, why don't you start?
One of our most impactful stories that I want to share is just about an individual patient experience. We had a patient, an 84-year-old patient who had been set up to do a video visit. And in that initial test with the CMA, the patient actually was having a hard time hearing. The patient had a hearing aid, and the volume in the speaker on their iPad wasn't really sufficient for the visit. So the patient actually went and got her husband, who had Bluetooth speakers, and was able to set up Bluetooth speakers so that the patient would be all ready for their visit with the provider. So love to bring this one forward and share it, because it does show that our patients, given the appropriate patience and time, really want to make this work and are more than willing to figure out how to do a video visit. So I think that's one of our best successes that we've heard throughout this experience.
I love that story. It's like Bluetooth speakers as a workaround for missing hearing aid. Put that in the operational guide, right?
Absolutely. Definitely put hard of hearing patients in your guide so you can help troubleshoot.
Yeah, exactly. That's good. Dr. Downey, how about you? Something to share?
Yeah, I think on this theme, obviously, in the time of the COVID crisis, there's a lot of, truly heroic things going on. This is less so, but what we've seen is patients actually just asking for video. Patients in their 80s saying, hey, I had a video visit last week. Can I do the same for my follow-up? Mm-hmm. I think I and a lot of people were skeptical about, really, can we provide cardiovascular services over something other than in-person visits? I frankly thought it would be yes, but not so much. But here we are at greater than 98%. We've got patients asking for video. And I think absolutely we can provide care this way.
Great. So Dr. Downey, Jenny, and Ginger, thank you so much. We know you're very busy, and we appreciate your time being on this week's COVID-19 briefing and MedAxiom Heart Talk. Thank you for being here.
Thank you for having us.
Thank you.
And thank you, everyone, for tuning into this week's COVID-19 briefing. Don't forget, medaxiom.com/COVID-19 is where you'll find the resource page. We'll continue to bring you these special episodes which address the most pressing COVID-19 issues facing CV programs and practices each week. And if you're enjoying these special programs, as well as MedAxiom Heart Talk, please tell your colleagues. They can subscribe on Apple, Google, or wherever they get their podcasts. And if you'd like to give us feedback about the podcast directly, send an email to hearttalk@medaxiom.com.